Well, hello everyone, and welcome to the MedVR talk series. MedVR is a Chapter 180 nonprofit education and research organization. Our focus is on expanding the use of XR in healthcare through education and also building the ecosystem for healthcare for medical XR. We run an accelerator. We can get a couple of cohorts through each year who will take on an interesting challenge under the guidance of a clinician with domain experience. And I don't want to get too involved with MedVR because everybody's here for this to hear this talk. I'm absolutely delighted to have this talk on the application of avatars in mental health. And the reason is this team spoke about a year and a half ago. I found them in my regular search through the research literature, and they had preliminary results of their project, which I thought was very interesting, and so did the audience at the time. And now they just published in Lancet the results of their study, which is most of our talks in this talk series have one thing in common. They talk about the journey of the medical XR innovator, and this is when the study gets published is a key point in the development of the technology. So I'm very excited to have this talk, and we have a wonderful moderator. Dr. Margot Paul. She is a clinical assistant professor and co-director of the Virtual Reality and Immersive Technology program at Stanford Medicine in the Department of Psychiatry and Behavioral Sciences. We really enjoy having a domain expert as a moderator because it brings out so much more of the talk. And with that, I'm going to turn things over to Margot to introduce our speaker and get started.
Thank you, Steve, and thank you all for being here. I'm delighted to introduce our speaker, Dr. Farah Shiraz. She's the Chief Scientific Officer at HEKA VR, which is a Copenhagen-based spinoff from Cora VR. With a background in psychology and global mental health, she previously served as an assistant professor at the National University of Singapore, leading research on mental health, and has clinical experience supporting patients with severe mental health conditions. At HEKA VR, Farah drives scientific strategy and innovation, emphasizing patient-centered approaches to developing effective mental health technologies. She brings a rare combination of clinical, academic, and medtech expertise with a focus on creating solutions that truly addresses patients' needs. So we're really excited to have Farah speak today. And if you could have any questions, please put it in the Q&A chat, and we'll let Farah give her presentation, and then we'll have the Q&A after.
Great. Thank you, Margot. I will just share my screen so we are ready to go. And hopefully everyone can see my screen. So great. Thank you. Thanks, Margot, for the introduction. And thank you, Steve, for inviting us back to do these talks. It's always a pleasure and always a great conversation. So yes, I'm here today to present to you our solution for severe mental health, particularly presenting you our solution for treatment-resistant schizophrenia, where we have at HEKA VR developed this software to help these patients. So just I think that most people here probably know what VR is, but I normally just present just a little introduction of why VR is so useful in the mental health field. It is something that has been used for a long time, since the 90s, but we just haven't got there yet to actually having some implementation. And VR is this idea of it's real, but it's not real. So we're able to have these environments and practice in a safe, controlled environment. So what do we do at HEKA? So at HEKA, we actually develop software to help therapists conduct something called avatar therapy in VR. And why is that important? So we know it was mainly developed for patients who suffer from auditory hallucinations. And we know that for 75% of patients with schizophrenia in particular, they can suffer from auditory hallucinations. For a majority, these hallucinations can be very negative. Not all, but for a majority, it can be. And these are just some quotes from some of our patients that have told us about what their voices say to them. They can tell them to be aggressive toward others. They can tell them negative things about themselves, interfere with treatment. So as you can see here, it can have a massive impact on their day-to-day and their quality of life. And the current options out there for this population is not a lot. We have of course, antipsychotic medication, which is the dominant treatment, but we know that this has quite a lot of side effects. And for many patients, they actually become treatment resistant, around 30%, which means that, they've tried the medication, but they still have these voices. There are therapies out there, talking therapy, psychological therapies. Predominantly CBTP is probably the most evidence-based therapy for this population, but we know that this has a lot of sessions needed to show some effect and can be therefore time-consuming. Why is it moving? Okay. So there was this new idea and this concept back in 2014 by a professor called Julian Leff and a team back in London, who had this idea about avatar therapy. Now, the concept of avatar therapy, Julian Leff felt that, okay, what if we had a different approach to treating these patients and having a conversation with this inner voice that they have, these auditory hallucinations? So they did a small trial and they found significant reductions in voice frequency and distress. And this trial has been replicated, and most recently in 2024, showing these amazing results with these patients, where patients are able to externalize the voice into something called an avatar. So at HEKA, we kind of added to that and added this VR element to it, because as we mentioned, VR has this opportunity to expose people in a very realistic manner. So alongside our research teams, our collaborators, we were looking at developing a solution in VR using avatar therapy. So I'm just going to give you a very quick demo of what our software looks like. So this is the solution here. So basically the patient will sit with the therapist, and the therapist will ask, okay, we're going to create your voice. So what does your voice look like and what does your voice sound like? And our software is able to really customize what the voice looks like and what the voice sounds like. So you kind of sit together in the first couple of sessions and try to figure out what they believe that their voice would look like. And our software is able to really customize the face firstly. So as you can see all the different boxes there that you can try and work together through with your patient. And you can change the face size, the width, the eye distance, so to try and get it as close as possible as what the patient believes. The next phase is this voice modulation and voice creation. And this is where you sit with the patient and you ask, okay, what do you think the voice sounds like? And the therapist will record their voice, which is what you're modulating. And then you, again, just like you created the face, you kind of do this sort of tailoring and personalizing of the voice as well, using the gender. Is it a more female, masculine voice? Is it higher? Is it low? So all these different components that you can, again, really customize with. And this is the interface that the therapist will see. So you can see on the right-hand side here, this is what the patient will see when they have the VR headset on. And it starts a bit like exposure therapy in terms of having first 2D. And when the patient feels comfortable enough to be faced with their voice, then you can go into this 3D avatar. So you will see it now come up. And the button here is between the voice therapist and the voice avatar. And this is where the therapist is able to become the voice of the avatar. And that's the beauty of this therapy, that the therapist essentially can play this role of being the therapist and then also being the avatar. This is what the patient sees when they put on the VR headset. It's again a 360 view. So if they move their head around, they're able to look around the room also. But you can also imagine that this is quite scary. Some of these patients, particularly our treatment-resistant patients, have been experiencing voices for over 15 to 16 years in our trial. So yeah, this is something that you can imagine can be quite anxiety-provoking for patients. So we do have at the end of most sessions that we had this debrief where the patient could actually go into this relaxation environment at the end of the therapy. We're very proud of our software, that we have had this co-creation with patients along the way. Right from pilots, we kind of presented our software, and added a lot of additional areas thanks to the input from our patients. So we have additional environments to make it more realistic of where patients hear voices, because of course it's not just in a clinical room. So we have a bus setting in particular. This was something that was very much highlighted from the feedback from our patients. And then we also have this living room environment. Another really nice addition was about this whiteboard feature. And this was when patients were faced with their voice, they became super anxious and worried, and sometimes would forget what to say. So we've added this whiteboard feature where you can actually add a statement to help patients, to remind them what to say, but also to remind them of the statements that they want to say to the voice. This is what the setup looks like. The beauty of our setup is that it can be done in one room. And that is a real benefit in several ways, particularly for the safety of the patient, for them being exposed to their voice. That can be quite, like I mentioned, very anxiety provoking. So to have the safety of the therapist being right next to you actually really adds to the therapy. But also just the logistics. Having the therapy in one room can really help. I don't know how it is in your settings, but it's hard enough to get one room, let alone two rooms. So yeah, this is a really nice addition to the therapy. This is the hardware that is involved. So you need a gaming laptop, noise-canceling headphones, because as you saw from the picture, they sit quite close together. So that cancels out the therapist's voice being heard by the patient, a therapist microphone, and then a VR headset. So it's not a lot of hardware for very sophisticated therapy. So it's a lot of information, but I wanted to share some of the more realistic and what the therapy actually looks like in a very short documentary. This is Celia, who was actually involved and right from the start of a pilot study, and agreed to be followed for a documentary. And her journey was followed, and I'll just give you a little insight into her story.
Skal Sille nu have behandlet sin skizofreni med virtual reality-briller? 22-årige Sille Jutta Storgård lider af skizofreni. Hver dag fortæller 8 forskellige stemmer i hendes hoved, hvad hun skal og ikke skal. Ved første behandling skal Sille lave en animeret karakter, en såkaldt avatar, af sin mest nedladende stemme, Christina.
Person går en tur i skoven med Sille. Hold din kæft.
Du skulle da selv holde din kæft.
Skal jeg holde min kæft?
Ja. Hvor er du bare god, Sille. Hvad?
Det føles meget skræmmende, fordi jeg ved godt, at hende, jeg kigger på lige nu, det er ikke Christina. Og hun går fuldstændig amok ind i mit eget hoved,
Så det er voldsomt.
ja.
Efter 2 minutter kan Sille ikke holde til mere. I dag skal Sille snakke positivt om sig selv for at genopbygge sit selvværd.
Selvværd? Jeg har da ikke noget selvværd.
Det er jeg faktisk begyndt at opbygge lidt.
Er du begyndt at snakke med nogle mennesker, der kan bilde dig sådan noget chat ind?
Nej, jeg tror bare, jeg er begyndt at lytte til de mennesker, jeg snakker med før.
Hvorfor lytter du ikke til mig? Jeg plejer da altid at være den, du lytter til.
Jamen, Christina, du kan godt lide at nedbryde mit selvværd, og jeg vil gerne have det opbygget.
Sille har fået det så godt, at hun nu vil indvise sin mor og lillebror i, hvordan hendes verden som skizofren ser ud. Nu er det tid til det, Sille er mest nervøs for. At afspille Christinas stemme for andre.
Okay. Det kommer nu.
Men er det her, jeg skal sidde, tænker du, eller bliver du bange for mig?
Jeg ved ikke, om du synes, jeg er mere farlig på den her. Jeg kan jo godt lide at skræmme dig lidt.
Jeg tror, du har behov for, at vi stopper. Fordi jeg kan se, at du bliver ked af det.
Jamen, jeg ved ikke, hvad der sker.
Ja.
I kan godt høre det, ikke?
Jo. Hvorfor reagerer du sådan der? Er det...
Fordi det er kun mig, der kan høre det. Jeg synes, jeg har det mærkeligt. Det er som om mit hoved, det står fuldstændig stille. Og jeg aner overhovedet ikke, hvad fanden der foregår. Der er fuldstændig slukket over.
Silles stemmer er næsten forsvundet.
Jeg nyder jo, der er en form for. Det er vanvittigt fantastisk. Men det er bare rigtig mærkeligt.
Du føler dig tom, når din stemmer ikke er der.
Sille skal nu til den aller sidste behandling i forsøget, hvor hun skal sige farvel til avataren Christina.
Sådan. Jeg kan godt se en ændring hos dig. Synes du, at du har det bedre nu?
Jeg synes faktisk helt ærligt, at jeg har det meget, meget, meget bedre.
Er det så sådan, at du ikke har ret meget brug for mig mere?
Ja,
Skal jeg ligefrem gøre det at sige undskyld eller sådan noget?
det synes jeg faktisk ville være rigtig rart, hvis du gjorde det.
Er du sikker på det?
Ja, jeg synes ikke, du har opført dig særlig pænt de sidste mange år, så jeg synes faktisk, det ville være på sin plads, hvis du sagde undskyld til mig.
Undskyld, fordi at jeg har skældt så meget ud. Og jeg synes, det er fedt at se, at du er kommet i kontrol.
Tusind tak.
Sådan, Sille.
Ja.
Pust ud. Træk vejret helt ud i maven. Stille og roligt.
So that is a really moving short film there, and if you're interested in watching a longer version, you can just reach out and I can share that with you. But I think what's most powerful for me in that video is when she shares the voice with her family, and I think that is something that a lot of these patients haven't had the opportunity to do. And I think the fact that she says, "Can you hear it? Can you also hear it?" and the disbelief that her family can actually hear that voice, I think is a really powerful and can be, one of the mechanisms of action of change of why this may be so effective. But yes, so Sile isn't the only one that this has had an impact on. I'll just present to you, as Stephen mentioned, we've just been published in the Lancet Psychiatry earlier this year, using our collaborators, VIRTU Research Group, who conducted this very large randomized control trial. So this was called the challenge trial. They recruited 270 patients, predominantly treatment-resistant patients, where they were compared with the supportive counseling group. So 140 in the VR group, 130 in the supportive counseling group. The mean age of the patient group was around 32, and the mean duration of the auditory hallucination was 15 to 16 years. So it's a very long time. The sessions last 7 sessions, so it's a very short treatment over a 12-week period, and it was done across 3 regions across Denmark. So this is just a little bit more about the inclusion-exclusion criteria. You can see that the criteria was quite broad to try and get as many patients in as possible. Again, if you want to find out more about the trial, please feel free to, I can link the paper for you. But yeah, just to kind of highlight that the main diagnostic treatment was schizophrenia, and the patients were having treatment at the time. So they were part of having medication as well at the time. So what is the challenge intervention? So the challenge intervention was this VR avatar therapy. It is a manualized therapy that our collaborators have created, where it's this sort of 3-phase of therapy. The confrontational dialogue, which is about gaining power and control, and that's where you saw that the patient learns to talk back to the voice and to have these verbatim statements that they want to say to the voice, and the therapist becomes the voice essentially. And that's the sort of flow of the therapy, about having these conversations and changing the dynamic between the voice. So a big part of the therapy is about finding out what relationship the patient has with the voice and working with that. And the 3 phases are this sort of power and control, self-worth and identity, and the last phase is about recovery and hope. The focus of the VR is actually around between 2 to 15 minutes. So it's not 60 minutes in VR. So it's a short amount of time. So a lot of the work is done as a preparation of when you go into VR. And the main focus that the patient has to focus on one dominant voice. And we all know that in this patient group, they can sometimes have more than one dominant voice, but it is important for this therapy to kind of focus starting on this one dominant voice because it's just one avatar that we can focus on to start with. So the key findings. So the primary outcome was the CIRAT, which is a clinical interview, and there was a reduced severity of auditory hallucinations, both at 12 weeks, which was clinically significant, and 24 weeks. So you can see the clear difference between the two groups. The secondary outcomes was the reduced frequency of voices, both at 12 weeks and 24 weeks after the treatment was completed. And this was also clinically significant. What was super interesting was that just by chance that the Challenge VR group had started off with a lower assertiveness score. And you can see here that they seem to increase their assertiveness, so increase assertiveness compared to the supportive counseling group, which stayed quite steady. So you can see that they were able to learn more, become more assertive and stand up to their voice. Also, they preferred this kind of treatment, and I think that's what it comes down to, right? The patient-reported outcomes in terms of the preference of treatment, and the VR therapy was greatly had greater satisfaction than the supportive counseling group. And one of the most unexpected findings was for some patients, they completely stopped hearing voices altogether. And this is not the purpose of the therapy at all, but it seems like for some patients, it seems to have this effect. You can see by 24 weeks, 11 patients completely stopped hearing voices. And just to put that in context, you know, when I highlighted about on average, these patients were hearing voices for 15 to 16 years. For this to be one of the results is pretty phenomenal. And this is just an example. This is Vibeke, who was one of those patients who stopped hearing voices. And after 27 years of hearing voices, she's now been voices free for the last 4 years. And her story is amazing. She is one of our patient ambassadors and likes to share her experience. And yeah, it's just a really inspirational story of now, you know, she's just started school again. She's able to read a book, all these kind of areas of her life that have improved after just having these 7 sessions of treatment. So we always get asked about the safety and tolerability. Was there any serious adverse events? Yes, but this is a very challenging patient group. There was one self-harm episode, which was possibly triggered by the therapy, but after analysis and the trial wasn't closed down. It's just, you know, one of the consequences of this patient group, unfortunately. As you can see, we had also similar in the control group, the suicide attempts, 8 in the challenge group, 7 in the control group. But the simulation sickness questionnaire, which is often used in VR, we can see that there was very minimal symptoms reported. And there was actually a really good compliance rate of 79% completing all 7 sessions. And again, for this patient group, that is again really a positive finding. So yes, just in summary with the results, this is definitely a potentially viable treatment for reducing the severity of auditory hallucinations in this population. And just, yeah, a summary of the results there. So what next? We are doing more trials outside of Denmark. I think a big push from HEKA is that we want this to go global, and we want everyone to be able to have these results. So we have some trials happening around the world. We have 10 active global trials, including one in the US right now, but also in Australia. We have a small feasibility study that just completed in South Africa, because we're really interested in looking at the cultural applications of our solution as well. And several sites here in Europe are also testing our solution. And, you know, this is just feedback from some of our therapists around the globe who are using our solution and using this therapy. And I think this one really highlights, particularly the one from South Africa, where our therapist highlights, I have never understood my patients as well as I understand them now with this therapy. So what is the future of HEKA VR? So we are actually expanding the scope outside of auditory hallucinations, and alongside our collaborators, VIRTU Research Group, they've just received funding to do this a trial with depression, with some patients with depression, also eating disorders, because we also know that for around 94% of patients, they also have this inner eating disorder voice, and this is something that can, again, be externalized. And we have our German collaborators did a small case study with OCD and showed really fantastic results. So they're hoping to do a big randomized control trial as well. And the purpose of this is sort of highlighting how these inner voices or negative self-talk can be externalized, and that's kind of where the benefit can be. Can we benefit from using this sort of software to externalize those inner voices and have those conversations with those voices? And that is applicable across many mental health conditions, not just for patients who suffer from auditory hallucinations. And this was our last cohort of therapists. We train our therapists around the world, and we were lucky enough to have 14 therapists trained just earlier this year, which ranged from Sweden to Turkey to Italy. So yeah, if anyone is interested in finding out more, please also reach out. So thank you for listening. There was a lot of information, but yeah, I'll be very happy to take your questions.
Wow, Farah, that was really interesting and a great use of avatar therapy for a severe mental illness. I'm so happy you showed that video as well. It was really poignant to see in real time how impactful it can be. So thank you so much. So for all the participants, I see sometimes some people have started asking questions in the chat. Please, if you could ask in the Q&A box, that way it's streamlined, that would be great. And so I think a question that I had is, as I was listening is, I know that there's a therapist that talks and responds as the voice. And I'm curious, with the advent of AI, I'm curious if you see AI taking on this role, or if you've thought about incorporating AI at all within this therapy, and what the pros and cons would be there.
Yeah, I mean, AI is definitely on everyone's agenda right now, right? But I think for this patient, because it's such a new therapy right now, especially with this patient group, I think in having the AI component is just very challenging and a risk that we're not ready to take yet. But it is definitely in development and looking into that area, because it is quite challenging for the therapist. I think they always report to us that they find it really difficult to say these negative things to their patient, because it's so out of our norm to and doing this role play, essentially you have to become a bit of an actor. But yeah, I think it's definitely in the pipeline. I think we just need to build the research base a little bit more to be able to train models effectively enough, because you need to have enough information for them to be able to say the right things.
Absolutely.
So I think the more trials that we have, the more information that we will get to allow the AI to respond accurately, because there's nothing, especially with this patient group. I think it's such a difficult, challenging patient group to treat anyway. So yeah, I think it's definitely on the agenda. I think we just need a bit more research to be able to create a good model for it to have that learning, the machine learning that it needs.
Yeah, absolutely. That's always a risk with a really vulnerable population. And I'm curious too, if you've had, I know there are certain types of therapies. I know, for example, I think it was something like Talk to Freud, where the patient would be in that role of the therapist and in the patient role itself. I'm curious if you've had, or if you tried a model where the patient could actually talk as the voice as well, to even further the exposure and then respond in the patient's own body.
Yeah, I mean, that's an interesting idea. And it's definitely, you know, the more trials we're doing, the more interesting ideas we're coming with. So yeah, I mean, right now, you know, it's just focused on that one dominant voice. And then, you know, maybe next phase would be to be able to have two avatars that you can have two, you know, so it's so many different avenues. This is just the starting point. But yeah, I think that's a super interesting concept as well. Yeah.
Yeah, thank you. I also love that you're applying it to other mental health
Yeah.
disorders such as depression and OCD and externalizing those other negative, the self-talk really.
Yeah. Yeah, and it's actually shown, I mean, the results for the eating disorders will hopefully be out next year. They just completed their randomized control trial. And we know from early results that it has had, again, a really fantastic impact on this patient group in particular. We also know how challenging it is. There's, again, not many treatment options for this patient group. But being able to externalize that inner eating disorder voice is, again, seeming to be something super impactful and just another alternative. I think what we believe that this can just be part of the toolbox for psychologists, psychiatrists to use, you know, and see how they, right now it's quite manualized and, you know, it needs to be because we started off with such a challenging group and vulnerable group, like you said. But hopefully the more research we do across different areas, we can see the applicability. And we're always interested in finding out different ways of this to be treated. You know, a lot of times in therapy, we have this chair work that we do. You know, imagine you're in a child sitting across you. What would you like to say? Well, our software is actually able to externalize that. Yeah, so it can be used in multiple ways, which we believe is the future for this software.
Yeah, absolutely. And so I'm curious where you see this software evolving in an ideal world. I mean, even if you're to keep with the same protocol and the same model, would you want it to evolve to look even more realistic, or do you find that where it's at right now is just as effective in theory?
Yeah, we were just having this conversation earlier because we have a fantastic PhD student who's been working with us to help modulate the voice. So right now the voice can be a little robotic sounding, but we are actually making the voice sound more human and accurate. And again, I think that could also add a great element to our software. Also, the avatars right now, again, they look quite robotic looking, I guess you can say. But this is kind of twofold. We've talked with our patients, we involve our patient ambassadors, we involve our therapists throughout our product development, and making more human faces is kind of 50-50 at the moment, because we have some patients who say that this is enough exposure, you know, but for some it may feel that it would be more useful. I think we also have to remember that for this patient group, particularly for the ones who experience maybe a trauma-based voice, having a much more realistic human face may be more difficult to have when they're exposed. So it's sort of thinking about maybe we will have a dial of more realistic, less realistic. So we are also in development constantly, and that's the beauty of development and having all this feedback from trials and allowing us to make also the avatars more customizable as well. Because for some patients, maybe they don't hear a human voice, maybe it's non-human. So this is again another addition that we're looking at right now.
Yeah, I see. I think what you're saying, which is really important and that makes these treatments more difficult, is that everybody is very different and unique, and what works for one person be detrimental to another.
Exactly.
And yeah, as Philip was saying, the uncanny valley effect. Yes, absolutely. And so with that, I think another question that is coming to my mind is, have you found from patients that it's important that the voice of the avatar sounds as similar as possible to the voice in their head for the treatment to be successful?
I think, you know, from the trial, we had a positive impact on around 7 out of 10 patients, whether that was a reduction in symptoms, whether that was a severity, you know, so it seems to be working in this context. Of course, we can improve it, and we will improve it. Whether that will make a difference to the results, will it make it better? Then that's something we have to wait and see. But it seems to be something about just externalizing that voice right now that it seems to be having this really positive effect. So yes, I'm sure if we make it look better and make the sound much better, will it have an even better effect? We don't know. That's hopefully what we will see. But, you know, already at this level, I think the results are fantastic. And for us, the dream is that it's just something that all this patient group can have and utilize, because there's just not enough options out there right now.
Yeah.
And we haven't really evolved. I think schizophrenia treatment hasn't really evolved that much in the last 50 to 60 years. So yeah, and having this technology in mental health, I think mental health, we're a little dinosaur when it comes to technology. We're getting there, but we're way behind some of the other disease areas. So I think this is just such an innovation in the area.
Yeah, absolutely. And as a clinician, the more tools in the toolbox to have for each individual patient, the better. Absolutely.
Yeah. I mean, I worked with this patient group when I was doing clinical work, and it's so challenging. And then, you know, seeing that this was an option or could be an option. I mean, we're not there. We hope that it can be. Yeah, so it's frustrating because we want everyone to be able to use it. And, you know, people have seen us online and asking, where can I get this treatment? And it's it's heartbreaking to be like, oh, we're still in research. It's not been implemented yet, you know? So it's really, yeah, it's really difficult situation to be in, because I think so many people are fed up of, and we're not trying to replace any kind of treatment. Like you said, Margot, it's more as having this as an addition and complementing part of the toolbox that people can use. And I think that's also important to highlight. You know, we're not sitting here trying to say we're going to replace medication. Of course not. But I think this is also a nice addition to be able to have an alternative treatment, or a complementary treatment is what we believe this is.
Yeah, absolutely. I think it is important to highlight, because with these technologies being used as treatment, some of the pushback that I get is, oh, you're trying to replace this or in person, and that's not the case at all. It's just the tool, right? An extra tool for the toolbox. So thank you for highlighting that. And before I go on to some of the participants' questions, the last question that I'm having right now, and to what you said, is, you know, people are watching this and they're saying, can I have access to this, or where can I find this? And as a clinician, I mean, it's definitely looking promising, and I understand you need to do more research and make sure that it is safe before releasing it, and do the due diligence. When do you see it being potential, if things keep going as they are, when do you see it being released to the public?
Yeah, we are actually CE marked here in Europe, which means that we are commercial in Europe, so we can sell effectively. So yeah, we have you know, a new training coming up soon, and we have some private psychologists attending that training. And then once they're trained, they can implement it in their practice. So it is starting to become available. I think for different markets are different rules, right? So we're definitely ready to go here in Europe. But yeah, we just want to make sure that everything is, yeah, like you say, due diligence, and make sure that we follow each country's rules. We don't need FDA approval, which is good news from our side, because we are, like we said, a complementary. It's low risk. Even here in Europe, we are a class 1A medical device. And that is because the patient is never alone with our device. It's supported by the therapist, and that's where, you know, all the risk is with the therapist, essentially, because it's just part of therapy. Our software is zero risk in that sense, which is why we come at quite a low classification. But yeah, so yes, please reach out if you're interested to find out more.
Thank you so much. And some of the people participating have asked some questions here. So Susan says, do you have a sense of whether the various elements of the therapy progression have a stronger versus weaker influence on clinical outcomes, or do all feel critical?
Yeah, I think what was interesting with the results was that they did have exploratory outcomes looking at depression, looking at social functioning, and there was no clinical significant difference in those areas. These were exploratory, but I think it's probably because the therapy is so focused on gaining control or, you know, changing the relationship with the voice that and we know that those secondary outcomes are really hard to change. Depression is very hard to change. Quality of life is so subjective that the measures maybe aren't as effective in measuring that. So yeah, it seems to be that depending on your measures of what you're looking at, that it seems to be having an influence on frequency of voices. But yeah, I think it also, we know that it depends on how many sessions maybe as well. Right now, the number is around 7 to 8. Maybe with more sessions, it could have a different result. If it's a trauma-based voice, it might have a different impact as well. So yeah, so this is just, again, we need to do more research to find out sort of the mechanisms of action as well, of why is this working for some patients and more effective for others as well.
Yeah, absolutely. And then Philip asked, is there any learning how to use avatar interaction for open world interactions? Example, WebXR to make people feel safe. There's a project called The Safe Zone. It's about helping people with depression related to online bullies.
Oh, interesting.
Yeah, that is
We're
interesting.
not there yet, but yeah, that sounds super interesting. Yeah, I don't know if that's a statement or a question, but
Yeah, I think yes, I know it's interesting. I think what he's asking, correct me if I'm wrong, Philip, is maybe that can
oh, is it more interactive?
or can the patient learn how to use this interaction with the avatar for, I guess, to extrapolate it or generalize it to other open world?
I see what you mean. Yeah. Yeah. Okay. Right now, no, not in this context, because we're also an offline. So maybe I should add that we are also an offline system, which is great from a data protection perspective. So you don't need any internet or anything to use our software. And we don't have social scenarios yet in our software. Right now, it's kind of just the ones that I presented. So yeah, it's not like an interactive where you can have other avatars come in. That is someone else. So we're definitely not there yet, but interesting idea.
Yeah. It is interesting ways that you can take this, and we can think of so many ways, right?
Yes, exactly.
Extrapolate and generalize, and it's never ending. That's what's so beautiful.
This is what I love doing these seminars and just learning from everyone of what they think that this could work for, because of course we have our ideas, but also, expanding the scope in mental health, like how else could we use it in different conditions? So it's always great to learn from the audience as well.
Absolutely. And then Alan asks, so if visual hallucinations are experienced as outside the head, like externalized rather than as internal imagery, would you expect similar clinical outcomes? So I know we're focusing right now on auditory hallucinations, and I think the question is if it's an auditory with visual, maybe hallucination, or from outside, if the outcomes would be similar, or if you've experienced any of that.
Yeah, we don't know. I can't answer that question, unfortunately, because the therapy is so focused on auditory hallucinations and externalizing those. But yeah, who knows? Maybe that's another area. Yeah, another area.
There you go.
Yeah.
Yeah, absolutely. And then so someone said, I know you said you were less on this side, but Agatha asked, since I come from an interior and experience design background, I'm very interested in how the virtual environments are chosen. What design principles guide the creation of these digital spaces so that patients feel safe and engaged during therapy?
Yeah, that's a way too technical question for
Yeah.
me, I'm afraid. But I have not. But you know, we did try to make the environment as neutral as possible. You can see that ours was done in Scandinavia, so you can see that the rooms are very minimal.
It's like an
But-
IKEA.
Yeah, exactly. So, but I think what was interesting was that from feedback, we did include like the bus scenario, and that was from patients saying that often they hear their voice on the bus or like on public transport. So we have that environment. So we have selected environments. We have a classroom environment as well, because we are going to be actually, there's this trial happening with a younger population for first episode psychosis and a youth population. So we have this classroom environment. So the environments right now are selected very much in line with the patient group and what is feasible. We get a lot of questions about different environments of where people hear voices. And again, that is another area that will be added and modified when we do more research.
Yeah, sure. And something that I was just recalling is you had said, I think in the presentation, you said that in between sessions, they would listen or see the voice as an exposure. Is that correct?
Yes. Yeah. So
Take the headset home with them as well?
no, so they don't take a headset, but they're able to have like a transcript of so they have like a USB, so they can
Got it.
see what they've sent to. So it's kind of like actually they assign it like a bit of like a homework task,
Okay.
where they can have an image of the avatar. They can have these statements that they've said, so they can practice. If the voice comes back, then they can practice. And also that this has been one way that they can share it with their family if they feel that's what they want to do.
Absolutely. Okay. And then for the exposure, so I know in the video you showed it's 2D and then 3D, and it's in almost like, as you said, a very simple IKEA type showroom. Is it almost like a hierarchy of exposure, and then after they feel comfortable in that environment, they can then go and generalize and go to a bus or to other areas as well?
Yeah. And like I said, even the time in VR can be longer and longer. I mean, it's no more normally than 10 minutes because it's too much for them to be exposed. And it's also about hitting the sweet spot, because you don't want them to be too anxious that nothing goes in, but you also don't want them to be not anxious enough that nothing goes in. So it's also about checking in on the patient. So it's a lot of interactive, checking in from a level to 1 to 10. Where's your anxiety right now? Are you ready to continue? And I think that's what's really beautiful about this therapy, is that you can switch to the therapist's voice as well, in the therapy. So it's like, okay, now it's me, Farah, talking. I'm back. You did really well. Are you ready to go back in and speak to Christina? Okay. And then now I'm going to switch to Christina. So you kind of are always telling the patient what is happening. So it's not unexpected, just out of nowhere, you just go into the avatar. It's very interactive and it's very collaborative. And you also, the patient also has a panic button in case that it's too much, so they can press it and the avatar goes away. And we get asked, do they just use that all the time? Actually, no, they actually only use it when they really need to. And we know that for a lot of patients, their symptoms get worse in the beginning, but we know that in therapy anyway, whatever therapy you do, they often get worse, but then it does come down.
It's like doing exposure for PTSD, right? Prolonged exposure, or for simple phobias, right?
Exactly. It's the same kind of principles. And then it does go down after time, and then they are able to stand up to the voice more, and actually the therapy sort of switches into this compassion focused therapy, and the voice will change. And you saw a little bit in the video of I was just saying that to try and help you, so it's also depending on the phase of the treatment, and how ready the patient is to get to that phase.
Yeah, I thought that was such a beautiful progression, watching that patient be able to stand up for herself and gain some self-esteem and move to some compassion. It was a beautiful trajectory to see.
Yeah.
Absolutely. Okay, I think we had another question. Oh, Karina asked if you've ever tried using avatars that are non-human.
So we're not there yet, but sometimes patients, we kind of worked with what we have. So our therapist reported back that sometimes maybe it was just a shadow. So you would create maybe, just a completely black face and black hair. So you were able to, I mean, we've worked with what we have at this point. But yeah, this is definitely something that came up a lot from the feedback. So I think we are in the process of having character creation, where we will be able to hopefully have non-human avatars as well in that. So if it's got horns or if it's got different hair, etc., and try to make them more culturally adaptable as well across different countries. We've had trials happening across in South Africa and the US, which is much more diverse than here in Denmark. So of course we want to be able to cater for across the different cultures and ethnicities as well. So that's also definitely on the cards right now that we're doing in development at the moment.
Yeah, absolutely. I think that's great to see how different regions and areas of the world call for different types of avatars and scenarios.
And the great thing is that we sometimes get asked about translation, but because the therapist is doing the therapy, we don't need any translation. The main interface is just in English, but I think most people can do the gender and the platform. They can figure that bit out. But the actual therapy, because it's all led by the therapist, it can be done in any language. It can be done in any dialect. So that is also sort of really helpful in this intervention as well.
Yeah, absolutely. And Alan just asked if the voices are sometimes actual people in their lives.
Yes, so it can be. And that's where, it can be a bit challenging with to try and create the exact voice. I mean, we were just talking today about sometimes, maybe, especially in the non-auditory hallucinations, for example, for eating disorders, sometimes it's their own voice.
Yeah.
We're also trying to figure out, okay, maybe that's also something we need to add, that they're able to talk back to their own voice. So yeah, I think, the more we do and the more ideas we get and the more therapists we speak to, because we have now trained over 60 therapists, we get a lot of feedback on, okay, maybe this could work, maybe this could work. So it's, it's great. And yeah, we hope we can modify it as we go along.
Yeah, absolutely. And I saw you're using the Quest.
Yeah.
And I'm curious if you've thought about using any other devices as well, or if in general, like you wanted to stick with Meta.
Yeah, I think we are exploring other devices as well, particularly because in the depression trial, they'll be using eye tracking.
Oh.
So we've been looking at different devices that will work better with that. So we are constantly trying to look at better ways of, management, and also we're looking to see if we can measure anxiety as well in patients when they are doing the therapy. So looking at wearables, etc. So there's a lot of different ideas to try and understand why it works for some patients better than others. This is the first largest RCT that's happened. So and alongside it, we were also developing. So it's kind of hand in hand. This has worked.
Yeah.
So, maybe in 5 years, you'll see a completely different version of this. And I hope I come back. Maybe even next year, I'll come back and present and show you the next phase. But yeah, even right now, the way that it is, it's ready to go. It still works. So that's the beauty of it.
Yeah, it's so exciting. I know hearing all of this, these new innovations and different treatments. I mean, you can just keep going on and there's dreams, and that's what makes this feel so exciting. And as technology is evolving, who knows, as you said, where we'll be.
Yeah.
Absolutely. Well, thank you so much, Farah. I mean, this was just so interesting and so exciting for me personally as a clinician to see how VR is being used. And I think, when I'm as a clinician and I use VR, to think the perfect use of VR is to enable patients and people to do things that you couldn't do in real life. And so using this and externalizing a voice as an avatar is such a great great use of the technology. So thank you so much.
Thank you. Thank you for seeing the potential, and we hope that this is something that can be utilized for people like yourself to use in your practice. So yeah, super exciting to see the next steps.
Yeah. Well, I'd like to thank our audience for joining us. We will post a recording sometime in the next week, so that if you want to share it with anyone, you can. Again, I'm super excited to see the progression of this application, going from idea to test to trials, and that's the way innovation happens in this field. Thank you, Dr. Paul. I very much appreciate your expertise in moderating, and thank you, Dr. Shiraz, for coming today. In the middle of October, we haven't settled on a date yet. It's either going to be the 14th or the 16th. We have Veronica Landhauer and Alexander Baznov, who are PhD candidates at the University of Heilbronn, that are working on using XR to treat alcoholism, which is a really interesting application. And we'll have Dr. Thomas Volpers from the Center of the German Center of Neurodegenerative Diseases, and also a research professor at the University of Magdeburg, who will be the moderator. It was a great paper that was presented at IEEE VR. So we're looking forward to that, and just check back with us or check your email and register and come. And again, thank you, Dr. Paul. Thank you, Dr. Shiraz. We'll see you folks next time.
Thank you so much. Take care. Bye.